Hey guys, welcome back. This is going to be a short and sweet one on NG tubes. I'm going to talk a little bit about percutaneous endoscopic gastrostomy tubes, which are also known as PEG tubes or G tubes, and jejunostomy tubes, which are J tubes, as well as enteral feeding. So buckle up, okay? So first of all, the learning objectives, we're going to make sure that you guys understand why we put these tubes in people, what the indications are for enteral feedings. We're going to talk about contraindications and complications of NG tube insertion, look at what equipment we need. You guys eventually are going to be demonstrating insertion of an NG tube in a mannequin, maybe in a real person, you never know, and describe the technique and understand the indications for PEG tubes and J tubes, okay? So nasogastric tubes. This shows you the route. So you're going in through the nair and going through the nasopharyngeal down into the esophagus and into the stomach. Okay, this is what an NG tube looks like. You see it has markings on it so that when you measure, you're able to trim that tube to the appropriate length for the patient. When you're measuring to insert an NG tube, you're going to be measuring from the tip of the nose to the earlobe, right? And then from the earlobe to the xiphoid process. It's just below the sternal notch, like right about here, okay? And this picture was the best one I could find that really depicts when you're putting an NG tube in, you want the patient doing a chin tuck and drinking because their swallowing pushes the tube down for you. It's effortless. Okay, so you measure from the tip of the client's nose to the earlobe, and then against the throat down to the xiphoid process, about half an inch to an inch below the sternal notch. Always assess the nares for patency. Nobody's symmetrical. Sometimes you'll see one is bigger than the other. Go for the bigger one, right? Lubricate your tube. Give them a cup of water with a straw. Let them do a chin tuck while they're drinking the water through the straw, and then just boom, 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 boom. You push the tube up, and it just goes right down. Check the back of the throat with your pen light and you will see the tube at the back of the throat. And then, of course, we're going to confirm placement with an X-ray the first time, always, to make sure that it's in the right spot. Sometimes it's helpful to keep one hand behind the patient's head. I would do that, like hold one hand here and boom, 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 the tube is going in. And that just makes it a little easier for the purposes of insertion, okay? Make sure you tell them to keep drinking the sips of water and swallowing. So this way it's going to help the tube go into the stomach and not into the lung because you don't want to go into the lung. I am going to pause really quickly. Okay, so we had a little delay there. Sorry about that. But anyway, yeah, it's helpful to keep one hand behind the patient's head while you're putting the tube in, and it kind of keeps their head down too, gently, right? Have them drink the water, like I said, and the chin tuck. And that's, those are the easiest ways to get the tube where it needs to be. Why? Why do we put a tube in? Well, sometimes we put NG tubes in because of diagnostic uses. If somebody's got an upper GI bleed, we can insert an NG tube. We can see how much they're bleeding if they have esophageal varices. Also, administration of radiographic contrast dye. We can insert contrast dye into the stomach and then put them underneath an X-ray and do a series of radiographic pictures, X-rays, watch the dye go through the intestines. And we're looking for tumors or obstructions, that type of thing. For feeding purposes, we can feed you through an NG tube. NG tubes can stay in about 7 days, though. They're not meant long-term. They're short-term. If the person's malnourished, sometimes pre-operatively, we will put an NG tube in to give somebody some additional nourishment. You'll see that a lot with, surgery for cancer, right? To try to fatten them up a little bit, give them some nourishment. There are certain conditions, like if somebody's had a stroke and we know that it's temporary and they're starting to improve, we can use an NG tube to feed them and then get rid of the NG tube once their swallow comes back, that type of thing. But the most common reason for an NG tube is gastric decompression, and this is the one you need to know. So what we're doing is we're dropping an NG tube and we're connecting it to the wall suction, low intermittent suction, so that it's drawing out any gastric contents, whether that's bile or air or any other fluid or food that's in there, usually because of either a paralytic ileus, that's the number one reason, or some type of bowel obstruction, so that the bowel won't rupture. right? Because if you have a paralytic ileus or an obstruction, everything in your body is South Philly. It's one way. So air, even air going down, will push towards that obstruction and make the bowel rupture. So we don't want that to happen. So we put the NG tube in, and it slowly will suction out, any fluid or any residual contents. We can also use NG tubes to deliver medications. Remember this, when you're putting medications through any tube, whether it's a PEG, a J, or an NG tube, medications have to be administered one at a time. You have to be able to crush them. Any med that ends with LA, LR, XR, all those things mean long acting or sustained release, right? You can't crush those meds. So you'd have to call the physician and change the order to either another form, like a liquid or something, something that's the same med, but a different form of it. And the med should be inserted one at a time and a flush in between each med. That is the only right way to do it, okay? This is a Salem tube, okay? There are different types of NG tubes. The board likes to ask about this. A Salem is a double lumen NG tube. That means it's got two things. I'm going to show you right here. See, there's the end of the tube, right, that goes into the stomach. And then right here at this end, you have this blue lumen and then this other lumen, two lumens. The blue lumen is a vent. It's just to aerate it, okay? Nothing goes in that or should come out of it, right? It's just for aeration. If you have to ambulate a patient with this type of tube, you would clamp it, but make sure it's above the level of the patient's waist. Otherwise, as they're walking with you, gastric contents are just going to be falling all over the floor, and that's a mess, okay? So make sure the tube, I used to pin it up to their gown, right, when we would ambulate, okay? That's a Salem. And let's see. Here are the two types of tubes. There's your Salem with the two lumens, and this is just a standard 11, it's called, 11 tube. Just a plain one lumen NG tube, okay? That's the most common. And here, this is the way we secure it to the nair. There's a thing that we do with the tape. We kind of flip it over, and it keeps it secure, okay? This poor gentleman has, anybody want to guess what type of tube that is? You can see the insertion site right there. Gastric. That's a PEG tube. That's a PEG tube. That's a gastric tube. That goes right into the stomach, right? So that's what they look like. This one actually looks pretty darn good. The insertion site looks good, okay? And here we can kind of look at the inside of what it looks like. With an NG tube, like I said, in through the nair, up and then down, and through the esophagus into the stomach. G tube directly into the stomach. A J tube directly into the jejunum, the part of the small intestine. And this is what it looks like when it's hooked up to wall suction. You've got your tube, right? That's attached to this canister. And then on the wall, there's a dial. And you could have continuous or intermittent suction. It can be high, medium, or low. So typically it's low intermittent suction. And the canister will fill up with whatever is draining from inside the stomach and the intestines. Usually it's bile, like a greenish looking material. And your job is to empty that canister, measure it and empty it and document what it looks like. If it has any foul odor, if it's got any blood in it, those are important things to note, okay? Oh, did that already. Did that, my bad. Going the wrong way. Okay. So enteral feedings, what are indications? Why would somebody need to be fed other than through their mouth, through a tube, an NG tube or through a G tube or a PEG tube or a J tube? So different reasons, okay? Whenever a patient can't get adequate nutrition orally, we have to look at the reasons why they can't get it. And then we also have to look sometimes at ethical reasons if it's an end of life situation. It's always better to give somebody enteral rather than parenteral. Parenteral feedings are through an IV. That's where we bypass the GI system completely, okay? That's TPN and lipids, which we'll learn about later. But enteral feedings are better if they can't take in things orally for lots of reasons. Physiologically, nutritional needs are better met that way, okay? So here's a little table that I put in here. Why does somebody need an enteral feeding? Somebody's unconscious, right? They're in a coma. They had a brain injury. Somebody's got a neuromuscular swallowing disorder, dysphagia because of a stroke, post-CVA, that's a stroke, multiple sclerosis, Parkinson's disease, physiological anorexia, which is loss of appetite caused by a disease process. People with HIV, AIDS, people that are septic, people with liver disease, and cancer patients oftentimes have no appetite. Sometimes we have to, if they're going to get better and there's a good prognosis for chemo, radiation, or whatever, we want them to have some nutrition. If they have an upper GI obstruction, something up here that's blocking their ability to eat, then, we could go in a different way. Dysmotility. In other words, for some reason, there's no motility in the digestive tract up here to be able to move the food down. Inflammatory bowel disease, short bowel syndrome is another one. Increased nutritional requirements. This is a big one, cystic fibrosis. These kids lack pancreatic enzymes, and we're going to learn all about cystic fibrosis, but make sure you understand, if a child with cystic fibrosis is losing weight, that is your priority problem that you need to intervene, and oftentimes they'll need a feeding tube and pancreatic enzyme replacement, etc. Also, somebody that's had significant burns, and psychologically, if somebody's so depressed, you really have to be severely depressed or have a bad case of anorexia nervosa where you're skeletal, where we'll put a feeding tube in, right? Inflammatory bowel disease, short-term use, sometimes we'll use it, and access during surgery, especially with head and neck cancers, any cancers that affect up here, that your ability to chew and swallow, okay? All right. Contraindications to an NG tube. If they have a basal skull fracture, an unstable C-spine injury, a nasal or pharyngeal or esophageal obstruction or ulceration, you can't put an NG tube in. Tracheoesophageal fistula. A fistula is like a hole, right? Can be like a tunnel. So if there's a hole or a tunnel in the trach or the esophagus, obviously no NG tube. Any strictures or tumors, post-laryngectomy. Cancer patients, they will have sometimes the larynx removed. And so any surgery here, we're not going to put an NG tube, we're going to put a PEG tube usually. Actively bleeding esophageal or gastric varices. A varice is a dilated vein, dilated blood vessel really, in the esophagus or the stomach. Usually you see this with alcoholics and liver disease. And what can happen is they can rupture and they will just be pouring blood. If they're actively bleeding, we're not going to put an NG tube in. And also clotting disorders, we're going to be careful, cautious, right? Because we don't want to disrupt anything and make somebody bleed out. Complications. The biggest one is you go in the wrong spot. You stick it in the lung. Instead of getting into the esophagus, you go into the trachea. And you would think, well, Miss Mary, won't they choke? Not always. Sometimes you stick it in the lung and they don't even flinch. And how do you know? Well, X-ray, you're going to do X-ray to confirm, but also gastric contents. When you aspirate gastric contents, they're going to be alkaline because the lung is an alkaline environment. So it's going to be a high pH, like a 7, an 8, right? Whereas the stomach is going to be below a 5 generally for pH, right? And when you're putting it in, if you meet any major resistance, don't try to force it. There could be something going on. There could be a lesion, a tumor, or something like that, and you don't want to cause more damage. Let's see, what else? And then this tells you the equipment that you need. You need your tray, your gloves, and it's not sterile. It's just clean, not a sterile technique. Your gown, nasogastric tube, tissues, syringe, usually a 50 milliliter syringe, which is a big fat syringe. And to discontinue it, that's the easiest. You just take off the tape, let them know what you're going to do, make sure you've got the right patient, and literally, but when you take it out, you must measure it to make sure that what went in came out intact. And that's where we're going to leave off for now. And I'll do PEG tubes and G tubes and J tubes a little bit later. So au revoir. Till next time. Bye.